What would you do if right this second you felt a crushing pain in your chest while you were completely alone at home? There is nobody there with you. Your phone is sitting in the other room, and you have about 8 to 10 minutes before your heart could suffer irreversible damage. Up to 65% of those who die from a heart attack pass away before ever reaching a hospital. The vast majority of them didn't die because there was no solution. They died because they didn't know exactly what to do in those first critical minutes. In the next few minutes, I am going to teach you three specific techniques that we as medical professionals use, methods that anyone, especially those over 60, should memorize. These techniques have saved actual lives, even in situations where someone was entirely on their own. But before we go any further, there's something you must realize. What we are covering today isn't printed on typical office flyers. It isn't the sort of quick advice you receive during a rushed 5-minute visit. It is exactly what I would explain to my own father to prepare him for the absolute worst case scenario. Please stick with me because what you are going to learn today could literally be the dividing line between life and death. My name is Dr. William Lee, and I have spent over 20 years in clinical medical practice. I have worked in emergency departments, served in coronary care units, and sat through deeply painful conversations with families who arrived just a moment too late. They arrived too late not because the event was impossible to prevent, but because the person suffering from it didn't know what to do or unfortunately took the wrong steps. I want to change that dynamic for you today. Let me share an experience that profoundly impacted me at the beginning of my medical path. I remember a specific patient, I will call him Manuel, who was 68 years old. He was a retired, highly active man without any serious cardiovascular history. He took regular walks, watched his nutrition carefully, showed up for routine checks, and generally took great care of his health. One Tuesday morning, his wife went out to buy groceries. Manuel stayed behind by himself, and within half an hour, he began noticing a strange tightness in the center of his chest. Assuming it was basic acid reflux, he lay down on the living room sofa to rest it off. When his wife came back home 90 minutes later, Manuel had slipped into unconsciousness. What could have been an easily treatable episode with a total recovery resulted in lifelong heart muscle damage. While he survived, the change to his long-term independence and quality of life was profound. What was the weak link here? It was not his heart. The weak link was simply a lack of key information. Manuel had no plan of action, and that absence of knowledge cost him a portion of his physical heart muscle forever. Manuel's story is not a unique exception. Unfortunately, it represents the baseline. According to data from the World Health Organization, cardiovascular conditions take nearly 18 million lives worldwide each year. Specifically, heart attacks alone account for approximately 9 million of those losses. There is a specific statistic that stands out most to me as a physician. Over 50% of these individuals pass away before ever setting foot in a hospital. Across multiple global evaluations, the typical window a patient waits before finally contacting emergency services after their symptoms start is between 2 and 4 hours. Imagine waiting 2 to 4 hours when every single moment counts. We in medicine use a standard rule of thumb: time is muscle. With each minute that elapses during an active heart attack, the heart suffers cellular loss that cannot be reversed. But we are here to break that cycle today by equipping you with the practical details to take action correctly, even on your own. In order to manage what needs to be done during an event, it helps to understand what is occurring within your body. Once the mechanics make sense, the protective actions naturally become clearer. Let me offer a comparison I often share with my clinical patients that stays with them. Think of your heart as a bustling city powered by millions of essential workers, the muscle cells working 24 hours a day all year long without a single break. For this city to thrive, it requires a constant delivery of key supplies, vital oxygen and rich nutrients. These resources travel along dedicated expressways known as your coronary arteries. What exactly unfolds then when one of those key roads becomes entirely blocked? Over several decades, a composite material known as plaque quietly accumulates along those arterial pathways. Picture it much like the scaling and mineral buildup on the inside of an aging pipe. A combination of cholesterol, fats, inflammatory materials, and calcium gradually creating a crust along the lining. For quite a while, this deposit remains stable, causing no outer discomfort, but occasionally an unexpected trigger offsets that balance. This can be a sharp spike in systemic blood pressure, intense emotional stress, or an abrupt physical strain, causing that fragile surface to rupture. This is where the acute crisis starts. When this tear occurs, your physical systems view the break as a normal wound and implement its usual healing protocol, rushing platelets directly to seal the area. Platelets are like your circulatory system's rapid response crew. They aggregate immediately around the fissure and initiate clotting. The issue is that this clot completely seals off the vessel pathway rather than gently healing it. Instantly, all tissue past that blockage is deprived of its oxygen supply. The millions of cellular workers within that region of the system find themselves entirely cut off from fresh nutrients. This leads to a highly critical timeline that many do not fully appreciate. Heart muscle tissues begin failing in a matter of short minutes rather than over hours. If oxygen delivery stops for 20 minutes, those first cellular groups face irreversible damage. By the 40-minute mark, the damaged perimeter begins to expand significantly. Within 6 hours without intervention, a massive portion of that target region can experience cell death, also known as necrosis. This compromised muscle tissue is lost permanently. Your heart cannot repair or rebuild itself like your skin or other tissues. What ceases to function is gone forever. This explains why, when early signs surface, each fleeting moment directly decides the amount of functioning heart muscle you are able to preserve. On a more encouraging note, and I want you to remember this point, modern emergency services can reopen that vessel pathway, clear the clot, and reestablish standard circulation in less than 90 minutes from your hospital arrival if you move quickly. This clinical intervention is known as a primary angioplasty, and it has the capability of preserving an essentially healthy heart structure. But first, you must survive the transit. To achieve that safety margin on your own, you must implement the correct steps in those early windows. Before we cover those 3 methods, I have a quick request. If you are finding this material informative, consider subscribing to our space right now by selecting the registration button below. I focus on these weekly updates specifically so you have access to clear, structured health strategies tailored for those over 60, backed by reliable clinical studies that are straightforward to follow. In the comment section below, let me know your feedback by typing a 1 if you like the video, or a 0 if there is any area you would like to see changed. Hearing from you in this simple way provides fantastic guidance for the channel's work. Now let's detail the 3 protective actions. The first, most fundamental approach on our list is what I term the primary 60-second emergency routine. It is a straightforward series of steps, but following them in order can play a decisive role in your outcome. Step 1. Identify the early warning signs and avoid disregarding them. Failing to recognize the signals is one of the most widespread, risky errors made. What actually occurs in daily life rarely resembles the dramatic episodes seen in films, such as sudden collapsing chest pain. Frequently, and notably among those over 60 and women, these warnings are far more subtle. Let's outline them. First, a deep pressure or a feeling of heaviness centered in the chest area, which is not always experienced as a sharp ache. Many individuals describe it like a strong clenching sensation or having a massive weight positioned on the chest. This restrictive feeling can persist beyond 20 minutes. Second, outward radiating discomfort. This often migrates down the left arm, as commonly expected, but can also run up toward the jawline, into the throat, down your spine, or even affect your right shoulder. As in Manuel's experience, he reported a heavy sensation along his lower jaw just prior to becoming unresponsive. Third, a sudden breakout of clammy, cold perspiration with no obvious external cause. Your autonomous nerve endings initiate cold sweating as a classic stress warning when the cardiovascular system undergoes critical strain. This is a primary indicator. Fourth, a sense of nausea or general lightheadedness. Quite a few individuals, women especially, develop severe stomach upset or queasiness as their primary signal, sometimes without obvious discomfort in the ribcage, causing them to mistake it for standard indigestion. Making that simple misinterpretation is a common error. Fifth, a strong internal sense that a serious problem is unfolding. This might sound vague, but cardiologists recognize a clear clinical phenomenon where individuals feel a sudden, profound dread of impending danger or distress triggered by physical warning mechanisms. If you feel this intuitive concern, take it seriously. Please hold this central fact firmly in your mind. If you are past 60, manage issues like cardiovascular tension, glucose imbalance, elevated lipid panels, or have a history of smoking, and develop any collection of these signals for longer than 5 minutes. Proceed under the assumption that it is a coronary event until clinically ruled out. Avoid convincing yourself that you are merely dealing with a simple muscular pull, general digestion issues, or routine anxiety. Clinical training teaches a core rule. When in doubt, address the concern as a serious emergency, because if the issue is urgent and you choose to delay, there is no way to regain lost ground. Step 2. Call your emergency services immediately. This step is completely non-negotiable. None of the supplemental strategies we outline here are designed to take the place of professional first responders. Instead, they function as short bridges of protection while medical support makes its way to you. Activating help is your priority. Reach out to emergency services. If possible, retrieve your mobile phone or call immediately. Once you speak with a dispatcher, provide these direct, simple statements. I believe I am currently experiencing a heart attack. I am alone. My location is. And state your exact home address, noting any floor details if applicable. Dispatchers are systematically trained to manage these concerns, so keep the connection active. Leaving the phone line open allows them to offer step-by-step guidance, monitor your situation while transit occurs, and secures your exact coordinates should you become unresponsive. Another vital detail to consider during these moments can save critical minutes. Always unlock your entry door before emergency personnel pull up. While it sounds basic, medical crews regularly arrive at homes only to find locked pathways with the resident unable to reach the entryway, forcing teams to force their way in. Once you've notified dispatch, walk directly to your main entrance, unlatch or fully open the door, and then seat yourself in a secure spot. Step 3. Adopt a physical position that limits physical load on your vascular system. After you contact help and unlock the main doorway, sit in a deliberate physical pose backed by clear hemodynamics. Avoid laying flat on your back on the carpet. It is extremely important that you remain in a seated position. A common, deep-rooted assumption is that people should rest horizontally during medical stress, which is a very natural instinct to have. But laying down fully flat can actually elevate heart stress due to fluid changes. Flat positions increase venous return to the thoracic chest, meaning an already compromised cardiovascular system is forced to handle and cycle an increased volume of fluid. The ideal pose is a modified Fowler's position, and it is very straightforward to use. Seat yourself securely on a level floor space or within a sturdy chair. If using the floor, lean your spine comfortably flat against a structural wall. Pull your knees upward slightly to form an angle, keeping them supported on a cushion if possible, while letting your arms drop loose. This simple physical arrangement lowers internal fluid load, which minimizes the specific volume your heart is forced to handle with each squeeze while supporting comfortable breathing. Think of your heart like a mechanical fluid pump encountering stress. Would you want to overload the device or keep its load as low as possible until help pulls up? Naturally, you want to help it run under the least strain possible. Settle yourself into this physical posture, maintain smooth, calm breaths, avoid extra physical exertion, do not attempt to travel to a clinic yourself, and refrain from calling dozens of people. Reserve every ounce of physical capacity exclusively for supporting your system. The second method we recommend focuses on a heavily researched, highly effective clinical strategy for managing coronary blockages in home settings, utilizing standard aspirin. You might feel surprised to hear about such a common, everyday home remedy. However, once you understand how the active ingredients protect the heart tissue during a crisis, you'll see why a simple, inexpensive tablet should be part of your plan. To tie this back to the vascular blockages discussed earlier, the root problem is a thick blood clot constructed of platelets obstructing a major coronary pathway. Platelets are cell fragments that aggregate around arterial plaque tears. Aspirin, also known as acetylsalicylic acid, carries a vital therapeutic quality. It helps prevent platelets from sticking together to make clots bigger by intercepting specific enzymes that otherwise promote clotting. Expressed in simpler terms, Aspirin instructs platelets to cease clumping, acting directly to slow the formation of the clot-causing system blockages. Research observations are exceptionally consistent on this point. The major ISIS-2 trial, which remains one of the largest clinical analyses conducted on cardiac emergencies, reported that using aspirin promptly decreased patient mortality rates by roughly 23%. Nearly one-fourth of patients who might have faced terminal outcomes recovered because they took a single inexpensive tablet right away. However, implementing this properly is essential to avoid diluting its benefits. To administer the dose correctly, look for a targeted portion of 300 to 325 milligrams of non-coated aspirin. A typical tablet of 500 milligrams can be cut in half, whereas low-dose baby aspirins are generally too small on their own. The optimal solution is to have a single, non-enteric tablet readily accessible. The crucial piece of instructions here is to thoroughly chew the aspirin rather than simply swallowing it whole with a glass of water. When you chew the tablet, it rapidly breaks apart in your mouth and can begin absorbing straight through your sensitive sublingual mucosal layers. This enables the compound to reach your systemic bloodstream much more rapidly than forcing it through digestive pathways in the stomach. We are talking about several precious minutes saved when minutes directly dictate how much cardiac tissue is protected. Simply chew the pill completely before swallowing, similar to eating a small wafer. Let us review important clinical contraindications because details in medicine preserve health. Who should refrain from taking aspirin in an emergency? First, anyone with a history of allergies or reactions to acetyl salicylic acid or general NSAIDs. If you face past allergic reactions, completely skip this step. Second, those with active peptic ulcers or present internal digestive tract bleeding, as blood thinners can exacerbate these conditions. Third, patients who already use prescription anti-clotting or blood-thinning compounds such as warfarin, Eliquis, or Xarelto. Layering aspirin over these specialized compounds can noticeably increase systemic bleeding hazards. That is why I consistently advise discussing this potential home strategy with your personal physician during a routine consult. Confirm whether having emergency aspirin fits with your personal medical profile before any emergency develops, as these safety choices are best reviewed beforehand. If your doctor clears you, you have no contraindications or anti-clotting treatments, and find yourself facing sudden cardiac warnings, keeping and chewing a tablet can preserve critical time as help heads toward you. I also want to clear up a piece of dangerous advice occasionally seen on digital platforms. Specific video uploads suggesting the use of common painkillers such as ibuprofen or diclofenac as a substitute during emergencies. Taking those alternatives is clinically unsupported and presents major risks. Ibuprofen actually blocks the positive blood thinning qualities of aspirin, and data links those pain management tools with poorer recovery rates in cardiovascular events. Do not rely on acetaminophen, common painkillers, or similar remedies. Aspirin remains the single household pill backed by real clinical data during these events. Remember this and share it with your household. The third concept represents an area that is frequently misunderstood due to persistent viral theories. Over many years, social messages and video platforms have presented a certain technique, often marketed as a hidden life hack, known as cough-induced CPR. Let me share the actual medical facts regarding this concept candidly, because my role is to provide you with reliable science. The core claim behind cough-assisted chest compression is that if you believe you are about to pass out, coughing forcefully over and over can help maintain blood flow. The logic proposes that intense, rapid coughing increases thoracic cavity pressure, momentarily driving a small amount of oxygenated blood toward your head to sustain conscious seconds. This clinical concept originally stems from a paper printed back in 1976, focusing on patients on active heart monitors within hospitals under strict doctor supervision who developed rhythm changes. As frequently happens on modern websites, this specialized laboratory detail was taken out of context, overly simplified, and shared widely as an ideal technique to practice at home alone. Real clinical research points to a different conclusion. Groups like the American Heart Association, European Society of Cardiology, and Red Cross are aligned in warning that cough-assisted procedures are not suitable as standard emergency guidelines for home settings during blockages, and several solid physiological details support this warning. First of all, vascular blockages and acute cardiac arrests are different medical emergencies. A heart attack is an obstructed pipe, whereas arrest occurs when structural electrical signaling stops coordinated rhythms. Coughing holds narrow theoretical function only inside specific impending arrest contexts rather than classic physical attacks. Second, executing intense cough cycles while your cardiovascular system experiences blockages directly raises systemic oxygen demand and can put more stress on heart tissue. Third, if physical changes are already intense enough to affect your conscious levels, coughing with real physical force is functionally unfeasible. Most importantly, prioritizing cough patterns over immediately reaching out to emergency dispatch delays essential care during those critical earliest windows. During emergency situations, developing anxiety and stress is an entirely expected neurological reaction. The brain naturally identifies an intense risk and switches on your autonomous fight or flight signaling. This activates hormones like adrenaline, which runs counter to what your heart needs by raising cardiac frequency, increasing systemic vascular tension, and significantly lifting cardiac workload. In short, elevated distress forces an already suffering heart muscle to perform more mechanical labor, similar to forcing an automobile with active mechanical problems to run at peak capacity. Implementing structured breathing can stimulate the vagus nerve, initiating your calming parasympathetic systems. Taking steady, measured breaths can ease elevated heart rates, lower vascular resistance, and scale down oxygen requirements. It doesn't dissolve blockages on its own, but during the transition until help reaches you, it preserves cardiorespiratory function and protects muscle structures from extra stress. It is easy to use and is known as the 478 technique. Remaining in the modified Fowler position, seated securely with back flat and legs bent upward, relax your jaw. Draw air in slowly and calmly through your nasal passages for a count of 4 seconds. Retain the air for 7 seconds, keeping yourself relaxed and loose. Exhale the volume of air gradually over 8 full seconds through your lips, imagining blowing gently at a small flame to maintain slow movement. Keep running through this calm breathing rhythm repeatedly. I'd like to share a quick experience involving one of my clinical patients, a 72-year-old retired school teacher named Consuelo who had lived by herself for several years. She remained incredibly active, organized, and focused on managing her personal health. After participating in one of our cardiovascular informational meetings and saving key guidelines, she kept her local emergency dispatch as a speed dial. One midweek evening, she noticed a sudden constriction inside her chest, quickly identified the signs, and notified dispatcher lines in less than 2 minutes. She immediately unlocked her main entry path, settled onto an armchair, and maintained her paced cardiorespiratory breaths. When ambulance crews pulled up 9 minutes down the line, she remained fully conscious, oriented, and managing an organized heartbeat. They transported her promptly, opened up her blockages, and 3 days afterward, she reached out to update me on her wellness. Her core sentiment was that understanding exactly what steps to follow provided her with a stable plan of action that kept her anxiety fully managed. Proper preparation does not make risks vanish, but it can supply you with a vital pathway when unexpected crises arrive. As we close out the key strategies, let's explore major common errors that older adults can accidentally make, because knowing what to actively avoid is often just as critical as having a set of protocols. Error number 1, attempting to drive yourself to a nearby clinical setting. You must never choose this path. If you are entirely on your own and suspect heart symptoms, leave the keys. Driving physically taxes your cardiovascular system, and going unresponsive while managing a vehicle poses a critical danger. Simply alert professional responders. Ambulances travel with continuous monitoring devices, immediate defibrillators, and fully prepared emergency medical technicians, while a regular car has none of those assets. Error number two, holding off on getting support in hopes that the pressure passes. Waiting on potential indicators can yield incredibly serious issues. If unexpected warning signals match those described and anger past 5 minutes, reach out immediately. Don't rationalize the tightness as passing muscle strain. Delaying access to care can translate to additional cellular strain on cardiac tissues. Error number three, drinking major volumes of water or consuming solid snacks. Eating beforehand can make sudden surgical preparation much more difficult under anesthesia if clinical interventions become immediate priorities. Maintain an empty digestive tract except for masticated non-enteric aspirin if medically advised. Error number four, executing physical activities to check your energy, such as walking around to rest off discomfort. Avoid any unnecessary strain. Walking rapidly places high workload and elevated blood requirements directly on compromised cardiac tissues when keeping physical strain fully limited remains your immediate target. Remain seated, breathe steadily, and avoid movement. Error number five, omitting to unlatch the doorway entrance. Delayed physical entry for arriving medical units. Trying to enter locked home systems can make a massive difference. Remember to undo latch pins immediately as soon as you contact first responders. There is also a significant physiological element to keep in mind. Most cardiovascular events do not strike completely out of nowhere. Clinical data indicates that in up to 60% of occurrences, our system generates subtle alarms several hours or even days beforehand. Learning to identify these initial prodromal warning patterns provides a precious window to secure diagnostic testing from your practitioner before any major emergencies ever unfold. What specifically do these early clues look like? First, developing unexpected, highly disproportionate fatigue that cannot be tied back to simple activity levels. We are referring to deep, exhausting fatigue that does not match your regular active routines and sets in quite suddenly among individuals who usually maintain good energy levels. It represents one of the most widespread initial alerts and is frequently brushed aside. Second, feeling a subtle constriction or dull weight when climbing stairwells, carrying parcels, or during moderately fast strolls that didn't present issues in past months. If physical tasks produce noticeable pressure, contact medical support immediately. We define this physical trend as unstable angina, representing a very common clinical alert before major coronary complications arise. Third, noticing an unexplained sudden difficulty catching your breath. If typical daily routines that used to feel simple and natural leave you winded, the heart tissue may be signaling reduced performance. Fourth, an abrupt onset of unusual sleeplessness combined with full body restlessness. Scientific reviews document that stress signaling systems activating before an event can interrupt normal deep rest patterns or leave patients with a general feeling of internal worry. Fifth, sudden, frequent cardiac fluttering or changes in rhythm. When under distress, your heart's electrical paths can cause brief changes that are felt as skip signals or elevated flutterings without a clear external reason. If you encounter a combination of these patterns, refrain from adopting a wait-and-see strategy. Make a short check-in call to your cardiologist, head directly to local urgent facilities, and secure a professional EKG tracing. An electrocardiogram is capable of mapping vascular signs before full structural tissue distress, which provides physicians with a safe clinical window to prevent full occlusion before it can happen. The optimal way to manage any cardiovascular challenge is through timely clinical prevention. As we close this guide, let us outline 3 foundational actions to keep ready at all times. First, if cardiac symptoms emerge, quickly notify professional rescue, unlatch your main home entryway, and sit in Fowler's modified position with knees raised and your back supported against the wall. Skip flat lying, keys, and waiting. Second, in the absence of direct clinical contraindications or other therapies, thoroughly masticate a single non-enteric tablet of 300 milligrams, remembering to chew rather than swallowing flat with fluids. Third, maintain smooth breathing using the 4-7-8 cadence to support vagal tone, reassuring yourself that you followed correct protocols and help is currently making its way to your location. Preparing these three safety strategies can serve to protect your cardiovascular health and outcomes. During my clinical practice, almost every survivor has shared a very consistent, powerful sentiment expressed in different ways. I wish I had been equipped with this information earlier. Real preparation and understanding represents an incredibly vital personal shield. Consider taking a brief moment to pass these tips along to friends or loved ones who might find them protective, since making such simple practices widely shared serves our communities well. If you have not selected to join our subscription community yet, feel free to register below to follow along as we outline cardiovascular and medication advice tailored for keeping those past 60 physically independent. In the comments section below, note your feedback by selecting a simple 1 if you found these patterns helpful, or 0 if there is any target area for change. Hearing directly from you supports our work greatly. Please note that the concepts reviewed in this guide serve purely for medical education purposes and are not intended as substitutes for professional physical evaluations, clinical diagnoses, or customized health prescriptions. At any emergence of potential heart signals, contact direct rescue options immediately. Before making use of aspirin therapies, discuss all pharmaceutical guidelines with a licensed healthcare practitioner.